currently for high-risk patients only, although there has been a risk creep, we use it smartly in patients where surgical valve has failed earlier than expected. We always like to bridge the secondary op so that patients get that benefit. We promised of 15 years durability. Why is that at present is, of course, we know only midterm results of valve in valve, and there are, of course, certain concerns with it. So planning becomes very important. And again, you need to use your heart team very creatively in these cases. So the main concerns is the interaction between three, and Rubin showed fantastic cases, especially the second case, where it showed that the interaction is not between THV, SHV, but also with native anatomy. And I think here we are going to mainly focus on surgical valve. So PPM can be a problem. As you probably noticed it in the first and second case he showed, there would be a considerable under expansion of the TAVR device as well. So positioning it correctly, choosing the right size so there's not too much flaring, too much oversize, and understanding each surgical valve which is separate is very important. So again, the most important thing you want is fixation and function. So this is very old slide. This is nearly 16 years old slide now. But what I like to show you is each valve is different. And it's very critical to understand not just the footprint of it, but how it translates into dimensions of these valves. So we classified these valves into three types, and that there was a reason for that. We realized that what we were using as label size and stent internal diameter was leading us to choosing the wrong size THV. We realized that the internal diameter, which is called the true ID, is very different, and it's very easy to understand why. Pericardial valves are artificial valves, so they can be sutured directly to the stent frame. It's a thicker material, so the suture becomes very close to the stent frame. While porcine valves are actual leaflets of the pig, so they need to harvest a bit of muscle shelf and tissue shelf to suture it down. So there's more material inside, and this is the reason the stent ID goes down by 2 millimeters in porcine. While mitral flow, trifecta, leaflets are outside, so actually they don't interfere with the internal diameter. We also know that positioning the valve is good, and I think Sushil, Ganesh, you can relate to this in the early days, that these were the kind of deployments we were doing. We started with 50-50 because that's what we were trained to do, and we realized that the hourglass shape is not very good for the valve function, while traditionally how we deploy it now, what I call as a top hat deployment, works actually very well. One thing to consider, if you are using any self-expandable valve, we always say this valve is supraannular, this valve is supraannular. It's only supraannular if you place it correctly. So again, really critical to understand in relation to surgical valve how you deploy it. And mistakes even happen today, especially sometimes with alternate access where we have to compromise and take a deeper position. So here's an example on the bench. You can see if I deploy a Evolutar in a Carpentier Edward porcine valve and match it, the leaflets will be here because the leaflets start at node 3. But if I implant it deeper, as that was one of my cases, you can see that we are intraannular. So again, deploying it correctly becomes very important in terms of achieving, better hemodynamics. So we published the second paper a long time ago about what is called as neo-annulus. Each surgical valve, the sewing ring is the narrowest diameter. That's where the surgeon suture the valve, that's where the stent frame and all the material hides. And you can see very easy experiment really, inflate a balloon and you find the zone, the narrowest sewing ring. So if you identify the sewing ring, then you can deploy any of these valves few millimeters below. Now, this is very important. We sometimes fracture valves now. If you want to fracture after deployment, it's very important to deploy the transcatheter valve slightly deeper, because if it is shallow, once you fracture the valve, it is going to get shortened and it might embolize or move up. So again, very critical that this so-called 4 millimeter below is if you are not going to fracture. If you are going to fracture, I would advise you should at least deploy 6 millimeter below to just be on the safer side. Some valves are tricky. This is a mosaic. In Medtronic, you don't see the sewing ring. And I don't want to tell you, but there was a case done, which was live case for a very early conference, where the operators felt that the top markers are the sewing ring, and the valve was deployed literally in the aorta by mistake. So we realized that we have to give some guidance in terms of how to deploy. And honestly, now all balloon expandable valves are very tall. So you can literally match the top of the frame to these 3 dots and you will be fine. And this is what it shows here. Now, Russian doll effect, again, very important because we didn't want the valves to embolize, so oversizing became very important. We initially started with 2 millimeter oversize in aortic valve. Now we are comfortable even going 0.5 because leaflets also taken. There is some pannus in the surgical valves as well, so it gives you a better expansion. And I think in India you have a lot of intermediate sizes you can choose from. So next app guidance is going to adjust to that 0.5 to 1 millimeter oversize. But you want to avoid PPM, you want to avoid severe under expansion or uneven expansion, and hence valve fracture really becomes important. Now, there are a lot of unanswered questions because we have never systematically studied it. Should you do it before? Should you do it after? What size balloon you should use? It's very simple in some ways, but can be very complicated. And it's very important to understand that you're fracturing the stent frame. So the balloon size you use should be at least 1 millimeter more than the stent frame. There is no need to overkill and go 3-4 millimeter above because the only thing you will do is create another rupture or a VSD. Now, the concept of valve fracture initially was applied actually in pulmonic position and also simultaneously in mitral flows by Henrik Anderson. And you can see this is what it looks like. I'm going to just play a bench video, which Sushina made it many years ago. Here you can see there is a pop, and same thing you can appreciate on the fluoroscopy. Now, one caveat about this is in mitral flow, what is visible is the sewing ring, not the stent frame. So if you see the sewing ring is still intact, it's okay. You don't have to go after it and try to break it. And there are 2 cases in the published literature where the operator felt that that's the stent frame. They kept choosing bigger size balloon and led to a VSD and embolization of the valve as well. So just be mindful about what is seen on the fluoro is stent frame or not. And there's an article coming soon to explain that. This is a balloon fracture in a perimount, and you can see that the stent frame is visible, the internal stent frame ring at the inflow, and this really works well. There is now 1 year data to show that there is a persistent benefit in terms of at least hemodynamics in these patients. And there are a lot of now good literature available in terms of balloon valve fracture, what balloon you should use, etc., and so on and so forth. So surgical valves are adapted to this. There has been a move towards making the valves expandable, and the reason behind this is you can fracture or expand the valve at low pressures. One of the worries of BVF is you can damage the leaflets, and as you can see, some of these leaflets, especially for valves like Eureka, are made of porcine pericardium, which is thinner. So I think it's very important to expose these leaflets as less as possible. Lastly but not the least, the type of valve affects coronary risk. As you can see here, if it's a mitral flow but a very generous anatomy, nothing's going to happen, as in our case here. But if it's narrow, a lot